Dr. Darrow is transitioning from his role of chief neurosurgery resident to assistant professor at the University of Minnesota. He's the PI for the eSTAND clinical trial. He's interested in functional neurosurgery and the treatment of functional diseases of the central nervous system, including epilepsy, movement disorders, spinal cord injury, TBI, and psychiatric diseases. He is co-PI of the Darrow Neuromodulation Lab at the university, and through his research, he works directly with biomedical engineers to unify non-invasive and invasive forms of neuromodulation with validated model-based approaches in control theory. He specializes in clinical trials and the application of novel devices and algorithms to optimize and understand neuromodulation approaches to treating disease. He'll review spinal cord stimulation for restoration of function after chronic spinal cord injury and findings from the eSTAND trial, as well as the novel personalized optimization method that was used. Thanks again, Dr. Darrow, for coming, and it's on you now.
Thank you so much, Dr. Tonkin. Are you able to hear me okay?
Yep, I can hear you okay.
Perfect. So I'm really excited to be here today. This was planned out a long time ago. And the purpose of the talk today was just try to bridge the gap between neurosurgery and PM&R in a very real and direct way. PM&R and neurosurgery go hand in hand, from spine to stroke to spinal cord injury, and we share a massive number of patients who benefit from our care in extremely complementary ways. Spinal cord injury in particular is a tremendously frustrating disease for neurosurgeons. We often only see patients in times of crisis, and historically, we often are only able to play sort of the carpenter role. When we actually in truth, though, we want to play a much more direct role in their functional recovery. And what I want to do today is really start a more in-depth conversation about what we sort of see as a glimmer of hope. The story I'll lay out today really represents the very neurosurgery and neuroengineering aspect, but there is a serious need to extend this work through the rehabilitation lens of spinal cord injury. And as I think it will glean, there is much more work to do there's so much more work to do that I often find it quite overwhelming, and we've barely even scratched the surface. So I tried to be strategic today, and I divided the talk into two parts. Really, the first 15 minutes is a sort of to the point rundown of the clinical outcomes that we've seen from eSTAND. That's much more digestible. As we all know, there's about, the 15 minutes is about the attention span of an adult. After that, I'll dive a little bit deeper while still trying to survey all the stuff that we're working on. And more of the details from the first 15 minutes will be in the latter portion. I'm certainly not going to spend 2 hours talking because that's just untenable for anyone. I hope that we can keep this casual, like Dr. Tonkin said, and just please interrupt via the method that he outlined, so that we can have really more of a conversation about this, especially things that are more interesting or important to you. So as Dr. Tonkin said, I'm very excited that at exactly 2 hours and 5 minutes ago, I made my transition from chief resident to assistant professor. Let's see if I can get this going. In the Department of Neurosurgery here at the University of Minnesota. And that's important because that's when the call switches over on my pager and I stop getting paid. So big milestone for me. I do have some disclosures. When we originally designed this study, I begged every device company I could, and Abbott came around, or St. Jude Medical at the time, came around and donated equipment. From all the work that we've done, we've developed some intellectual property that the university owns, and I am the chief medical officer and co-founder of STIM Sherpa, which is a company that basically works on optimization of neuromodulation more broadly, but hopefully will one day sort of churn the field enough that we can see some innovation for spinal cord injury. And obviously today I will discuss off-label use of medical devices. I will be talking about spinal cord stimulators, and they are not FDA approved for spinal cord injury specifically. And as I alluded to, the way I've outlined this is the first portion being the clinical overview, which is about 10 to 15 minutes. And then I'll go more in depth on the trial details. I'll talk about some parameter space optimization that we've been doing and have been very excited about. And then I'll talk a little bit about some spatial modeling, and then we can talk about the next generation of the study that's going to start here at the U, hopefully soon. But what I want to start with is something that has been brewing in the background of various labs looking at spinal cord injury for quite some time, especially really coalescing in the early 1990s. We've sort of known that if you carefully measure the activity, the muscle activity of the extremities with electrophysiology in patients who were thought to be motor complete, really more than 90% of those patients seem to have some ability to exert supraspinal influence over their movements. And that brought about and coined the term dyscomplete spinal cord injury. And if you pair that with another thing that we've known since really the 80s, that if you look at postmortem spinal cords of patients who had spinal cord injury, we now know that you can actually calculate or count a few percent of remaining descending tracts that pass through the site of injury in most spinal cord injury patients that are not an obvious transection. It's these remaining fibers and this subtle control that seem to provide a platform for neuromodulation. These few fibers, specifically the fibers that the cortical spinal fibers, inhibitory fibers, descend onto the segmental interneurons in the spinal cord rather sparsely. And without the normal density of cortical spinal projections, these segmental circuits are left unchecked. And we're all very familiar with this. These segments constantly reinforce themselves to the point that any small sensory signal or perturbation gets amplified and causes tremendous movement. And one way that this can manifest, and that we all are very familiar with, is the very complex world of spasticity. But what we know now, and it's been reported from at least 4 independent labs, is that if you perform spinal cord stimulation at the level of the segment, so much lower down at T12L1, the spinal segments that project to the lower extremities, in very simple terms, this floods the sensory system, and most of this stimulation really, we believe, affects the sensory roots primarily, which project onto those interneurons. And this may take quite a bit more stimulation than most people are used to when used for pain, but the result is some kind of modulation of those segmental circuits. And we believe that optimally tuning these circuits pushes the spinal cord into a state that is much more receptive to those few fibers that are still intact and descend through the lesion. And so far, the results have been encouraging. Now, I apologize if the videos do not work on this. I've done everything I can to try to make them work. But on the day after surgery, when we first turn the stimulator on, in participants that have had motor complete spinal cord injury for more than 5 or 6 and 8 years in these cases, as soon as we turn it on, really the first time, and we ask them to do a task, neither of them have moved their legs in since injury, really, and don't have any appreciable spasticity. As soon as we turn it on and ask them to do a task, they're able to do something. And I think that's the critical thing, is that now we have something to work with, and none of it's optimized, none of the spatial simulation is optimized. This is just very rough approximation, and this we found extremely encouraging. And we've captured these movements through surface EMG and a standardized, very regimented assessment of motor control called the brain motor control assessment, which some of you may be familiar with. It's sort of an excellent first start towards trying to rigorously quantify and actually use surface EMG, which we all know is incredibly noisy. And we see massive changes in the amount of power that patients can generate during time-locked volitional tasks when compared to periods of rest and reinforcement or with stimulation off. And these figures were published last year. And while it's certainly far from restoration or complete restoration, these movements are substantial when compared to no movement or spastic movement. Often we see spasticity immediately melt away. And now we showed in an upcoming publication that we're able to restore even enough movement to allow participants to cycle. And what you're seeing here is this MotoMed is a bicycle that pedals passively, automatically, at a constant rate. And I know the video is choppy. I can see that it's choppy. But without stimulation, we see that constant rate continue. But with stimulation, we see that the bike essentially stops and then allows the participant to pedal on their own at a variable rate. And if you quantify the amount of energy that we're able to achieve during this, we found in a very specific trial design, we found that stimulation by itself is not sufficient to really change the amount of power generated or how long they can pedal. In order to actively pedal the bicycle, it requires both stimulation and significant effort on the part of the patient. And effort alone without stimulation, or stimulation alone, does not seem to cause any change in how much energy they can generate. What really pushes them off the chart is this interaction term between effort and stimulation. And it's important to remember that despite some restored motor movements, almost all of these patients, 12 out of 14, are sensory complete. They have no proprioception, light or deep sensation. And we all know from other disease processes that patients that do not have any sensation or proprioception have a tremendously difficult time with motor control. These participants have to use primarily visual feedback to retrain and use these sort of new movements that manifest during their activities of daily life. And this, as they've used it during the study, after many months of stimulation, has led to a remarkable and unexpected finding. And that finding is that, surprisingly, after many months of continuous low amplitude stimulation, more than half of the patients we're seeing now are able to move, albeit less, without stimulation on at all. They're able to initiate a movement, a much more coarse movement, and usually a subset of the previous movements that we saw from them, with the stimulator off completely for many hours. And we've been able to quantify this, and in those patients that we see this movement emerge after many months, they continue to improve over time. Each study period here is 4 months at a time, and you can see that over time we see significant improvements. whereas there are still some of the patients that have not developed this, but we get more and more signs that it takes months, if not years, to even see the first inkling of this effect of what we think is obviously some kind of neuroplastic effect. Along with this is that we've seen that cycling, the same sort of experiment we were doing that I showed earlier, the patients that were able to start moving without stimulation were actually able to cycle without the stimulator on as well. Now, while improvements in motor function make really good videos, except on Zoom, spinal cord injury patients have repeatedly reported to prefer, if they had a choice, improvements in autonomic function, such as, number 1, restored sexual function, number 2, restored blood pressure when they have significant cardiac dysautonomia, and bowel bladder function. These are top priorities. These are patient-centered priorities. And we've seen really interesting changes and exciting changes in these as well. We've demonstrated that spinal cord stimulation improves the typical resting hypotension associated with spinal cord injury. And even when we tilt them on a tilt table test up to 70 degrees and we wait for their blood pressures to start tanking, we can almost always reverse the descent in blood pressure and bring it back up to normal acutely. And we can restore not only just the blood pressure seen here at the top, see if I can get a little laser pointer, not only the blood pressure, but the cerebral blood flow and cardiac contractility. And we can repeat this experiment and see massive changes between flat baseline, their symptomatic hypotension, and stimulation, which often is just slightly higher than flat baseline because it should be a blood pressure that would support them in the upright position. And as a result of improving cerebral blood flow, we see improvements in cognition in a very challenging task that we've done with DigitSpan and Stroop. We've shown that with stimulation, we get massive improvements that have been exciting. And I'm not going to talk too much about bowel, bladder, and sexual function today because we're really just starting to dig into this data. But this was some data from a year ago or so that we put together trying to get a good estimate of what was going on. And this was actively changing because the patients later in the study towards the bottom were at different time points in the trial. But spinal cord stimulation appears to significantly reduce bowel prep time in a way that is so profound that it has actually become the most favorite outcome of patients in the eSTAN trial, is going from what takes an hour a day or an hour and a half a day down to 5 minutes, which has been very exciting, but obviously makes terrible videos. So spinal cord stimulation also appears to modulate and mostly directly improve bladder function, but we're really only starting to dig into this, and only recently are we moving towards being able to do more in-depth urodynamic studies with a collaboration here with a urologist at the University of Minnesota. Most surprisingly and most unexpectedly, we now have a very robust finding that spinal cord stimulation appears to restore sexual function in a subset of patients that seems to be reliable now. We have no idea, obviously, how this mechanism may work, but we have seen it now in a good number of both males and females. We see very obvious changes in spasticity acutely, but when we look at patient ratings of their spasticity, at home, we're starting to see some trend towards overall improvement, which is interesting because a later finding I'll mention is that we find that spasticity may actually be a predictor for response from spinal cord injury. More significantly than even the spasms is we have seen now in the first 13 patients reported in this plot massive statistically significant improvements in quality of life, and a course of a curve of quality of life that corresponds almost exactly to what is more well known as the height curve, where we see a big change in expectations about what spinal cord stimulation can do at about the 6-month mark, which has been reported across a number of psychometric studies looking at adopting new technology or new changes in healthcare. And we also see improvements in the psychological domain of the WHO QOL and environment for some reason, with not really a significant change in social relationships, nor would we be expecting one. Lastly, we do see some modulation of symptoms of depression, but frankly, we haven't had much depression or symptoms of depression reported in the study, so it's a little bit hard to interpret at this point, but we capture this data to make sure that we're not causing harm. One of the main things that at least neurosurgeons talk about is whether or not spinal cord stimulation is safe to do in patients with spinal cord injury. Now, there's plenty of spinal cord stim that's done for pain after spinal cord injury. Been attempted many times for phantom pain and for neuropathic pain as sort of a last resort. And with the extra comorbidities of spinal cord injury, a big question that comes up is, is spinal cord stimulation a safe procedure? And of the first 14 patients that we've had no surgical adverse events. We've had no infections. We had one device fail after 4 months. We've had another big question we get is, how long can the stimulator be on? And our patients, we allow them to ramp up to 24 hours a day. And we test them across a massive range of frequency, pulse widths, and amplitude. I'll show you in a second. And lastly, a big question that's come up is whether or not, we're potentiating some kind of autonomic dysreflexia, which could cause increased rates of things like arrhythmia or systolic blood pressures that are too high, and we also see none of that. Oftentimes, what we actually see is during tilt is a decrease in heart rate when stimulation is on, and improvements in cardiac contractility. We see decreased rates of arrhythmic events and improved sinus rhythm in patients that have cardiac dysautonomia. We see less PVCs, and usually we see very stable systolic blood pressures that don't look like autonomic dysreflexia at all. This plot is really here just to show you what a wide range of parameters that we've used during the trial, during our optimization, which I'll talk about much later. We go from all the way from above 700 microseconds down to, 700 hertz down to 20, and we go from 600 microseconds all the way down to 100 or 150. And through all of these different parameters that we've done across a huge range of amplitudes, as you can see in this example, we have not seen any real adverse effects. We see movement, and at very high amplitudes, we see some increased tonicity, but that's pretty much it. So we believe that it's a very safe therapy. It's still surgery, and it still carries a well-known complication rate, infection rate, but it's certainly not worse than what we see in pain, and it could potentially be better because of the effect that it has. So just to summarize the first part of the talk, we believe spinal cord stimulation is safe in spinal cord injury, after spinal cord injury. We see that spinal cord stimulation can restore some volitional movement acutely and maybe volitional movement chronically through a neuroplastic effect. We see autonomic function improve acutely. And one thing I didn't really talk about, but that we have not seen, is autonomic function improve chronically off stimulation. We know that spinal cord stim does not alter normal cardiovascular function, and spinal cord stimulation may be able to restore some bowel, bladder, and sexual function, but these are sort of the edge of what we're working on, and bringing in more people to be able to better assess that. And we see significant improvements in quality of life, maybe symptoms of depression, and definitely spasticity acutely. So that's the first part of the talk. I'm looking to see if there are some questions here.
Would you like to go through some of the questions now?
Yeah, I think it would be a good time.
Okay.
We get into much more details later, but we can maybe answer some now.
Yeah, sure. So a couple of questions about autonomic dysreflexia. And so has that been affected by spinal cord stimulation, and also in terms of frequency of AD events since orthostatic hypotension improves?
Yeah, that's a big question that we are wondering as well. The fact of the matter is that this e-stand was basically set up and approved for thoracic injury. So we, at baseline, don't see a lot of AD events with severe hypertension. We really only see symptomatic hypotension, orthostatic hypotension. And so we don't know. But what we do know is that our collaborators have now seen mitigation of autonomic dysreflexia in some of the patients that were implanted overseas who had cervical injuries. That matches essentially what we see with sort of regression to the normal blood pressure for the patients in our study who have hypotension.
Okay. Is hypertension a contraindication if they have hypertension at baseline?
It's not. There is, for e-stand, we set some high systolic blood pressures during a 10-minute tilt, but we've never had anyone hit them. And it's just, I think that, the severe autonomic dysreflexia is just not as seen as often in thoracic injuries, or we just haven't seen it.
Sure.
But usually it's more cervical.
How long after initial injury do you wait to place a stimulator?
So we're approved for chronic, which means greater than 1 year. I'll show you in a little bit exactly what our data looks like in terms of time since injury that we implant. And so that will be a little clearer.
Okay. Dr. Balzer was commenting on some of the volitional movements seen, and they look kind of coarse, almost dystonic, and he was wondering about a comprehensive kind of treatment with physical therapy, medications, even botulinum toxin injections could be considered to assist in, kind of refining those movements if it's thought to be dystonic.
Yeah, absolutely. Dr. Balzer has way too much knowledge about our trial because he helped design it. It's complicated. Obviously, he's bringing up a very complicated question. We definitely think there's lots of room to help with, and I'll talk about today, sort of the rehabilitation path for this. We exclude patients, with botulinum. We try to wean patients off of medications like anti-spasticity medications, because we do see such profound effects from the stimulation that they can usually go off. Not completely always, not 100%, but 90% of the time we can get them off the medication just being on the spinal cord stimulator. Now that's been previously reported. There's lots of studies actually that are just not very well known, that have been trials that have looked at reduction in spasticity from spinal cord stimulation. And it seems to work. It's just not super cost effective. But yeah, absolutely. There's just a tremendous amount of tools that PM&R has that could make this, what I can only say is probably 10 times better than what we've done. This is just the bottom of the barrel.
Okay. Question here from our colleagues in PT. Does the level of neurological injury have any impact on extent of response to the stimulation if they're thoracic or lumbar?
That's a really good question. I'll try to address that a little bit later, but essentially every metric that we've done of extent of injury, measuring all aspects of the spinal cord or level, have shown no difference in outcomes that we have seen. And this is really important because we are all about trying to be as generalizable as possible. And we see no correlation at all right now. And I'll show you the spinal cords from many of the patients that we've done so you can see for yourself what the range looks like. But we've seen no correlation with level of injury. What we do see a relationship with is level of injury and dysautonomia, which has already been well documented.
Sure. Specific question about bowel programs. Have the needs for their bowel programs been like formally tested, or some of the patients with prior refractory constipation improved, or with reduced bowel meds? Or how have you been tracking that?
Yeah, we also we weren't expecting such a dramatic change in bowel function, and so we have not done any real very little quantitative testing. We essentially have used validated surveys as our primary means of assessment, and those validated surveys aren't great, but we're hoping that in the long run we'll be able to do some more quantifiable stuff. And I think the point that I'm guessing Dr. Balzer is making is that the bowel and bladder function, as everyone here knows, is extremely complicated and variable after spinal cord injury. I mean, you can have flaccid or spastic bladders, and so assessing a change or improvement is not trivial and requires actually a lot of work quantitatively to back things up. And that is where we're heading right now, but we have not been robust in those areas.
For those patients who have, kind of orthostatic hypotension, which is fairly common, have some of those patients been able to come off of, pressure support medications like Midodrine?
Yes. So we have one patient that was on Midodrine, and she has almost come completely off of it. The complication, as I'll talk about later, is that as of right now, the spatial target for restoring blood pressure is actually different from the spatial target for restoring movement. And so based on the devices we have, there is an inherent limitation in terms of how we can stimulate that does not allow us to do both at the amplitudes that we need simultaneously. We're getting there, and new devices we shouldn't have a problem with. But right now, it's hard to make everything better all at once and continue that just because of sort of inherent limitations on the technical side. But those are not real limitations. They're just these devices. I mean, remember, these devices were essentially pacemakers that were, remade for spinal cord stimulation, and they had some improvements in the 80s and 90s. But at the end of the day, they are still pacemakers, and so we're sort of retooling on retooling on retooling. It's challenging.
Okay, just a few more here, and then we can go on to the next section. Has there been any evaluation of development of other psychiatric symptoms other than depression?
No, we have not looked at things like anxiety or we have not used any other validated measures so far. It was really just to make sure we weren't, hurting anyone that we started tracking this data. Sure. And like I said, the biggest problem is when you look at the stats, mostly what we get is 0 from a depression inventory for 90% of the patients or 80% of the patients. So we just mostly just use it as a tool to make sure we're not harming.
Okay. Are there any predictors of the 50% who show later voluntary motion without stim?
Yes, there is a small predictor that I'll talk about, but it is essentially we see that pre-op spasticity is if you have a little bit of pre-op spasticity, that is better. It is somewhat small, but predictive of being able to see this response. Now we're talking about low numbers right now, so predictors Sure. are a little bit tough, but that's what we've seen so far.
Okay. Given that Harkima's protocol for spinal cord stimulator implant is grounded in the theory of central pattern generators and a robust therapy protocol, what is this study doing by way of robust therapy protocols?
Absolutely, yeah. So the previous group that published this actually in 2010, their theory was that by stimulating the spinal cord central pattern generators, they would see automatic movements in the lower extremities as a way to facilitate locomotion. And to their surprise, they found that they were actually, after 8 months of stim and rehab, the patient reported volitional movement, which is an unexpected finding. Since then, there have been really no updates in terms of, well, there's been some animal studies that have looked at what the underlying mechanism of this, but our findings and other groups' findings are not consistent with restoration of central pattern generators because we do not see automatic movements in the lower extremities when we stimulate. We see, of course, volitional movements. In terms of rehab, one of the reasons that we did this study was that all the previous studies were rehab intensive, meaning patients got rehab before, they got rehab during, they got implanted, and then they got rehab after. And rehab was intensive. These came from rehab labs. So as you might imagine, they want to know how rehab works. From our perspective as neurosurgeons, we're very competent in rehab, and it's well characterized, pretty well characterized effect on long-term recovery after spinal cord injury. What we wanted to do was disentangle stimulation and its effect from rehab. So we did not prescribe any rehab to any patient. The idea was patients would be able to continue to do their stable rehab programs that they've been doing for 5, 10, or 15 years. And from that, we're the only group that's been able to start disentangling that. And it's important because from our perspective, most patients cannot afford, and in the clinical world, are not able to gain access to centers that have locomotor training, nor can they afford it. And whether or not they could afford a spinal cord stimulator, also up for question, but it's important to be able to figure out how, this therapy, if it works out, will, eventually get to my patients. And that was a big consideration for how we actually performed this study.
Yeah. All right, last one, then we can move on. In patients with underlying chronic pain and spinal cord injury, are the settings and placement of the stimulator just got bumped out here. Are the settings and placement of the stimulator conducive to motor improvement equally effective for pain, or is the stimulator best used for one indication or the other?
That's a really good question. The short answer is we placed the stimulator in a different spot than is typically used for pain. What's really interesting is that what we have seen is there are a few patients that reported quite a few musculoskeletal pains before they had the stimulator implanted that have all improved after implantation. Because one thing I'm not going to really talk about today because we weren't really anticipating was that a major improvement is actually that patients describe constantly to us is their posture. We see really significant improvements in their posture, and they handle themselves differently in their wheelchair. And that, with their wheelchair and with transfers, has been one of the other things that patients have really liked. And after 8 or 10 months, say, when I turn it off, this is one of the biggest things that I miss because it's much easier to get around if I don't have that sort of abdominal sag that a lot of our patients have.
Sure. One more snuck in as a follow-up to that therapy question you had earlier. Have you been collecting information about the therapy that your subjects are receiving, even though you're not maybe focusing on that as part of your trial?
We are. We could do a better job, and we've actually gone back to patients to assess updates in their therapies during the course of the trial. And that, for the first 7 patients, is now reported in our latest publication that's already out, but is in, I don't know, right before they put it online. The abstract is up and it's indexed, but you can find that in online, and you can see sort of exactly the variation. And what we found so far in those first 7 patients are the one patient that went above and beyond and tried to do a lot more therapy actually had the worse outcomes or not as good outcomes. And that's really, I think, just a selection, that's sort of a cognitive bias, I think, that was inherent. But I don't think, we have enough patients to really assess both the effect of spinal cord stimulation and the effect of rehab in a systematic way yet. I think, we need to have a number that would be consistent with a power analysis like that. So 50, 100 patients is what really we need.
Right. Great. Thanks for catching us up.
Yes, thank you so much. It's really, really good questions. All right. So let's start over. We can talk a little bit more in depth about the details of the trial, since I know there are a lot of questions about that. So the ESAN trial specifically, we implant the spinal cord stimulator, not at this level, but at T12L1. We actually started higher, and intraoperatively, we do twitch mapping, 2 Hertz low frequency mapping, usually between 5 and 10 milliamps, where we try to do some directional stimulation to try to place the paddle low enough to capture most of the lumbosacral roots, but high enough because from animal models and from previous work, we know that the neuroanatomical target for restoration or modulation of sympathetic activity actually rests around the spinal level of about T10. And that's been pretty consistent. So in patients that have some dysautonomia, some cardiovascular orthostatic hypotension, or what have you, we try to get that paddle sort of splitting the difference here. And we're usually able to do a good job. And we got better, with every patient essentially. But that's sort of where we're settling most of the time, is at the T12L1 spinal level. And these stimulators, these are paddle electrodes, and no, I don't think that paddle electrodes are much better than percutaneous electrodes. I think percutaneous electrodes are just fine. We've seen some effects from percutaneous electrodes as well in other work, but it does give us a little bit more ability to direct the current, and it's cathodic current that is most effective. And we've shown now in a paper that we've put together that it's very directional. If you want to stimulate the left side, you put the cathodes to the left side, and you get very specific stimulation. And a lot of this current is stimulating what we believe to be mostly dorsal roots, not as much direct spinal cord stimulation, unless you're at very high current, which is still sort of being argued in computational modeling that's going on right now. I wanted to show you sort of in that later publication, I alluded to, this is a sample of the first 7 patients with spinal cord injury. And sort of what I want to point out is we're talking about real spinal cord injury, sort of what we see in clinic. We have severe areas of myelomalacia. We have sort of tethering posteriorly here, very thin cords. We see, areas of myelomalacia here, but we also see spinal cords that don't look that bad. And we see similar, really devastating looking cords, still some sliver of tissue. Here, not so bad. Here, hard to tell, but not so bad. So it's a wide variation of spinal cord topology after injury, and that's important because so far we've seen no correlation with any of this. When we originally designed the ESAN trial, Dr. Balser will be able to tell you, it was done mostly in the middle of the night between very long call days. And the questions that we have were, number one, is it stimulation that restores function? Is the function, is that movement that we're seeing actually volitional, which is harder to prove than you think? And does injury severity matter? Does the time from injury matter? Do we have to do rehabilitation before we put in a stimulator? And the significance of that question is that all of the patients that had previously been reported were, young, previous college athletes, a year or 2 from injury. They're cream of the crop. And most of my patients with spinal cord injury are not like that. Most of them acutely are older, and as time goes on are becoming even older. And then the patients that we see in clinic are often 15 years out as sort of the median or the average, and have had injury, have a family, are doing their thing, and are well adapted. Then the next question that we had was, when you turn this thing on, do we get sort of equal distribution of restoration? You get 5% in your iliopsoas and 5% in your gastroc, or what is sort of the variability there? Because we know that spinal cord injury is already highly variable. And so when we restore function, is that also highly variable? And my personal philosophy in my lab and my collaborators are very specifically focused on quantitative measures, because the more quantitative we can get, the closer to the truth, and the more we can check each other. And then obviously a big star around autonomic function. This is a complex area, but we have really good collaborators that are able to help suss that out. And then a big question for me was, I thought, if this is real, people are really getting better by just putting in a stimulator, which to us is a 45-minute procedure that's outpatient, then what is going to be the barrier for this long term? And my thought was, man, programming these things is going to be complicated. And for my patient that I know who lives right now in the middle of North Dakota and does not have access to anyone that even knows how to turn this thing on, the biggest barrier is going to be optimization and programming. So we focused heavily on that from the beginning. And then another sort of personal philosophy is that from the beginning, we wanted to do as much as we could from home, because that reduces the cost not only for the trial, but for long-term for patients that don't have the ability to live at the university that's doing the testing, which was required of previous patients and other studies. And the more we can empower patients from home and do validated quantitative things, the better. The inclusion-exclusion criteria sort of summarized. It was an adult. The injury could be between C6 and T10, but the edges of the lesion actually had to be below C6. And we've never found anybody that, we have one patient that will probably implant that's just on the border, but it's hard to find people that are right on the border. Usually they're thoracic injuries. They had to be AIS-A or B, they had to have full arm strength, and they had to have intact reflexes below the lesion. And that's important because that's part of the mechanism of how we believe this works. Exclusion criteria, we initially said, probably much to our chagrin, that we're going to exclude patients with extreme dysautonomia. So, patients who walk in with systolics less than 50 or go down less than 50 on tilt, or greater than 200 on tilt. We've never seen anyone even get close to 200. We've had a few patients come close on 50. Nobody that had botulinum injections for obvious reasons, because the stim may not be effective. No volitional movements present during EMG testing. No patients who are sick and maybe at much increased risk from surgery. And our study is pretty simple. The way it works is everybody goes through the same thing, except for the patients that have cardiac dysautonomia, they do more extensive tilt table testing. Patients come in, they get screened, they go home, they come back for enrollment, they get extensive testing, implantation, and then usually extensive testing the next day. Then they come once a month for 12 months, 13 months, depending on how you count. And they do at home, they use our platform for doing a couple things. One is some surveys, and one is a very simple triple flexion extension task that I'll talk about a little bit later. And then they finish their final study. We have a pre-screening tool that's online, so patients can go fill out a questionnaire and sort of know whether or not they even meet basic criteria. And this is sort of what the response, last year when I looked at this in August, we had 900 responses. And this was sort of the distribution that we saw of patients who had applied. Everybody knew that the levels were between C6 and T10, and this is what comes, and this sort of, meets my expectation. for what I would expect. The screening is very straightforward, history and physical. The MRI is usually the linchpin. We do EMG and tilt table testing. We have a pretty good record with screening. We basically have around a 50% hit rate. So we only invite people for screening that we think are going to make it to the trial, and about half of them have, more so later on. We do a lot of stuff during this study. Here are some of the surveys that we do that you can see if you just sort of glance across. As you can see, we have the neurogenic bladder symptom score, brain motor control assessment. We do the INSCI, PHQ-9, neurogenic bowel dysfunction scores, functional assessments. And we've added a bunch since we originally designed the trial. For example, we had to add surveys of orgasm because patients were reporting changes in their orgasm. So we had to find surveys that were able to capture that data. Enrollment, sorry, this is a little bit old, but we've done 14 patients now, and I think 11 of them are male and 3 of them are female. The average age is about the same, around 39. And before COVID, we were doing about 1 implantation every 1.5 months. So this is our chart of patients that we've implanted so far. They're not exactly in the order of implantation, but it's pretty close. You can see the spread of age, gender, and then years from injury. So these are not, almost none of them are within a year, and almost there's 2 within 2 years, and the rest we go out all the way to 17 years so far. And it's not because we're trying to, whittle away people that have older injuries. It's just that is how the cookies crumbled so far in the study. We're very specific about the order that we implant. It's first come, first serve. Doesn't matter who you are, as long as you meet the criteria. And here are the levels that we've seen: T3 down to T10, but very heavy in the middle. We have essentially 2 Asia Bs. One of them really actually has sensation, but 2 official Asia Bs. In the OR, like I talked about, we do a lot of mapping. And we use radiology to try to get it close, and then we map it and make sort of micro adjustments. And this is what it looks like in the spinal canal from the lateral position. On our brain motor control assessment, you can see these are the periods, the periods in which we are asking them to move in gray. And this is a subset of the channels that we are measuring from. And like I showed before, we are able to process this very noisy EMG data with the help of Tay and our student Nick, Tay Nutoff, BME professor. And we've made significant strides in improving that data analysis, looking at trends over time. And we see really significant changes between non-stimulation and stim. Now we're trying to do more assessments to look at breaking it down by the tasks that we ask them to do, and things like looking at a picture of the complexity of their movements. For example, off stim, when we ask them to do this 23-minute task, you can see that the complexity of their movements, or the EMG recorded, is not very interesting. And at least in the first 2 patients, you can see this patient had very limited movement, but this patient had quite significant movement. And we see complexity related to between the muscle groups and the things that we're asking them to do, the tasks. And you can see that a lot of the movements are coarse, just as you saw in the videos, but again, they don't have sensation. As I spoke about earlier, one of the more interesting findings that we've seen is this report from patients that really came from patients that they all of a sudden were able to move with the stimulator off. And it was strange. We get inklings of it from the data analysis, but it's not clear until it really happens. And then, you know, a patient will send us sort of a video of it happening where the stimulator's off and they're moving, and it looks like, oh, I don't know if that's real or not. Is it spasticity or what? But then you measure them and they don't have any spasticity at all. They're not rigid. And all of a sudden they have these sort of coarse movements. And like I said, they're not as good as when the stim is on, but it's way more than they ever had before with the stimulator off. Next slide. So we actually started recording, you know, and by eye, what movements patients had with stim on and stim off. And you can see with the stim on in these 3 patients, these are color coded based on the movement. And you can see that this is by visit, and the gray is we hadn't started recording, and every patient's at a different spot in the trial at a different time. And what we noticed was that the movements that they had off stim were usually a subset of what they had when the stimulation was on, but it was always much less, but also very early. And when we look at in log space, when we look at how much power they have during these volitional tasks, taking into account all the baseline noise and subtracting that stuff off, what we see in general is sort of a slow improvement with some people that have wide variability, but as we gain more and more patients, the picture's becoming clear that over time, there is a subset of patients seems to sort of progressively get better over time. And this is that plot that I showed you before, where in the patients that developed the ability, usually during this period, to move without stimulation, they continued on to improve, whereas the patients that did not stayed about the same. Also, as I alluded to before, those patients that were able to move without the stim gain have enough movement when compared to their baseline before the study started that actually improved enough that they were now able to actively pedal with this motor-med bike instead of it just passively moving their legs, which is different from before they started this study. And this is true both with active distance, how long they were able to pedal in a specific amount of time, and how much work they were able to do. And this brings up this, point that we have tried to make, being non-rehab doctors, that a lot of our patients that we see are not tip-top shape. They have contractures, they have significant muscle loss, they have significant bone mineral density losses, and the previous prior, or what other people were doing, getting them up and doing locomotor training, which we think is great, would not be safe. And so in that context, what we have been hoping for is to help carve the path or help others extend the path for how this will look like in the long run. In our mind, since we're doing stuff at home, our thoughts are that if you can start with a home therapy, which is almost mandatory in COVID days, is that a platform that we can make the first, make the first amount of progress that will enable us to get to the point where outpatient therapy or rehabilitation makes sense. And then from there, the patients that are able to participate in outpatient therapy and make significant strides, are they the ones that meet some criteria that eventually get to locomotor training? And we do so in a way that's safe and effective and appropriately uses resources, because we all know how expensive all of this stuff can be. We have to be extremely cost conscious while still providing the absolute best care possible. And for us, a lot of this comes down to remote data collection. And as you all know, those platforms are blossoming, and whether or not we can do so cost effectively, but with the best outcomes. one of the reasons that we looked at the MotoMed and this active cycling platform was that it was easy to do and potentially maybe with economies of scale could be done at home for the vast majority of patients, and provides us a quantitative way to measure a functional outcome that could be used as both cardiovascular exercise, which we know is all important, which we all know is very important, and also a way to navigate towards outpatient therapy. And the reason that we're doing this work is specifically for this narrative. How can we get our patients that we've now implanted and have done so safely, are showing some improvements, how can we get them to be in the best possible shape with the best bone mineral density and muscle tone to our rehab partners who will be able to take and use all the tools that already exist for spinal cord injury at this time. I'll talk a little bit more about the cardiovascular dysfunction, because not only because we have great collaborators in this area, but because this is one of those things that is really challenging. And we all know that, we all have patients on midodrine, but we know that midodrine is just not dynamic enough to meet the needs of patients during their day. I like this pairing that I've done between one patient who has significant dysautonomia and one that doesn't, because it shows how powerful our quantitative data is. On the left, this is a tilt table test. This is 10 minutes over the whole time period. This is the data point before tilt, and this is the tilt. You can see that we tilt, we wait 10 minutes, and we see some increase in heart rate would actually meet diagnostic criteria for POTS, but no real changes in blood pressure, completely asymptomatic, no problems. This patient's been doing well for years, no problems. The second one, we tilt, heart rate goes up, systolics eventually start falling. The systolics get lower and lower and lower, and eventually the patient tells us that she feels hungry. And that was surprising, but what we have learned by just screening patients is that there are a lot of spinal cord injury patients that have, completely unknown cardiovascular dysautonomia and orthostatic hypotension. And their interpretation of that orthostatic hypotension seems to be fatigue, hunger, things like that I would never guess if they had told me in clinic. Now, when we send these patients home with a blood pressure cuff and ask the blood pressure cuff to take blood pressures every 15 minutes, which all the participants love to do, what we see is in the patient that does not have, or the participant does not have dysautonomia on the left, we see a normal diurnal variation in systolic, diastolic blood pressure and pulse. Whereas in the patient that does not, or that does have dysautonomia, we see flat across the board, day or night. And this is significant. This plays into sleep and everything else. And for me, not knowing all of this beforehand, this was eye-opening. So in the first participant who doesn't have any problem, we did do some tilt table testing for safety, and we stimulated at the neuroanatomical site that we were successful in the other participant, and we saw no effect from stimulation, basically just noise. No symptoms, no nothing, just some extra muscle tone. We do the same experiment where we tilt the patient that has dysautonomia or orthostatic hypotension, and eventually they start falling. If we stimulate the lumbosacral roots, not the correct anatomical site, we get no effect. And at this point, in this particular experiment, this patient was very symptomatic. So we flipped it, and we flipped the paddle. So we're stimulating up higher at T10 or closer to T10, and we immediately see a rise in systolic blood pressure. Lagging behind that is we see a rise in cerebral blood flow. And simultaneously, lagging behind that, we see changes in cardiac contractility. And we repeat this experiment over and over again. It's a very challenging experiment to do. And repeatedly, we get the same result. Systolics go up from baseline, which is flat when they're tilted, and are much, much higher than when the patients are symptomatic. And going back to the previous figure, this is sort of typical in patients that have more subtle orthostatic hypotension. A big effect that we actually see is on heart rate. We see their heart rate go up during the tilt, and we turn on the stimulator and it settles back down to near baseline when they're supine, but not quite all the way because they are upright, and we turn it off and it starts to rise back again. Similarly, if you look at PVCs, if you look at any metric of EKG, we see really only improvements in events that you could consider to be proarrhythmic versus sinus, which has been very encouraging to us. This may help provide more safety for patients with these dysautonomias. And similarly, if you look at broad spectrum of the systolic blood pressure during all of these trials, we do not see big changes in their systolics at baseline or versus baseline. And nor do we see a whole lot, a big correlation between the systolic blood pressure change and the stimulation amplitude. Obviously, we see that the autonomic group, we see that patients in the autonomic group have lower blood pressures even while flat. So one thing we've learned is that CV dysfunction is really under-recognized, at least in our group, and also, you know, more widely. We know the literature supports that. And the other thing that's very clear is that the anatomical target and the type of stimulation that you do for cardiovascular is very different from volitional movement. Spinal cord stimulation appears to be very potent acutely when specifically targeted, but not, we have not seen a plastic effect yet. And that's critical because that would mean that patients would need ongoing stimulation, whereas for volitional movement, perhaps there could be more growth. So far we have not seen any adverse events during these pretty significant testing experiments that we've done with patients, except from just tilt itself. I want to do I want to talk a little bit about our optimization because it's novel and it's very relevant and applicable to other areas of neuromodulation. I think it will be informative. I have Zishi and Tay and Andy to thank for this. They tirelessly work on a very hard problem, but we're making significant progress. The basic premise of this problem comes down to something very simple. If you have an electrode that has 16 contacts, how many different combinations of stimulation can you make? And then if you combine that with a number of frequency, pulse widths, and amplitudes that you can put into the system, what does the combinatorial total come to? And it's sort of 43 million and about 4 million. There's some cool things in the device that help us give us more degrees of freedom that actually make this much higher, but you can see that there are a lot of possibilities. And so how do you figure out, you know, what the best settings are? Do we just use pain settings? Do we, and, you know, it brings up the question of, you know, how optimized are our pain settings? And this has been talked about before, but in spinal cord injury, it's a little bit different because we have different outcomes. So it's not just pain that we're looking at, it's all the roots of the lumbar sacral plexus, all of the bowel, bladder, sexual function, cardiovascular function. It's all these different things that may have different biological specificities. And the thing to know is that even if we do a really simple experiment we keep everything the same except just the frequency for this patient. And we ask her to do exactly the same thing. That's 20 hertz, it's 50 hertz. It's harder for her to put it back down. And then here's 100 hertz. Very difficult for her to raise it. And then there's 150 hertz, and we start to see much more sort of posturing in the feet. Just changing the frequency matters, and the optimization does matter. And our approach towards this was multi-scalar. We start with a simple way of trying to reduce this space down and find something reasonable. We identify a validated measure and focus in, and then we pair that with a validated behavior. And eventually the hope is that we can get this down all the way to electrophysiology in closed loop for each outcome. And what we started with was essentially by taking advantage of a very simple forced binary choice that we're all very familiar with. Whenever you go to the optometrist, they say 1 or 2, 3 or 4, 5 or 6. And essentially we can do the same thing with settings in a blinded fashion by having them evaluate, for example, in our study, 1 setting per day. And at the end of the day, answer a simple survey and do a simple task. And so we have a way of validating the response. Originally programmed by now a resident in your program, Nick Peterson, this enabled us to really start the process. And we've gone through many iterations, but the premise is still the same. By doing this very simple task, asking them sequentially questions about their preference day by day, we can quantitatively model their response and over time build a response curve that we can then use to find better and better settings. So in our case, we're looking at pulse width and frequency, and we allow the patient to adjust the amplitude within a range, because the amplitude has to be adjusted based on their positioning. And by doing so, they can optimally find it, and they are very good at that. We model their response, and then we have to pick new settings that we ask them to test. And we do that with a Bayesian optimization. And what this really boils down is looking at the model and saying, okay, what settings here would help make the model better? And so we pick a number of new settings. Usually it's 8 per month, and then we sequence them so that we get the most binary comparisons between every single setting, and it's usually around 32. And then they complete 1 setting per day. We ask them the same survey every single day. At the end of the day, it's a little bit more complicated because we do some for autonomic function as well, but that's really the main thrust. And we build these 2-dimensional response surfaces where the black crosses are settings they've completed. The gradient shows you their preference on the left and the uncertainty on the right. And this is all in log space, so it's not exactly what the frequencies and pulse widths are. But we take this response surface and then we algorithmically say what settings would be best to test next. And those are the red X's. And when we do this over month by month, we get better and better estimates of what their preferences are in a way that we understand where the noise is. We understand when they don't know the answer and they're just guessing. We can see that quantitatively and we can model that. And over time, we build better and better models of them. And you can see that in the first set of patients, if you look as the trial goes on month by month, we start from a very wide range of pulse widths and frequencies, and almost all the patients get down to a pretty narrow range of frequencies, but quite variable pulse widths. And we think that this is just because the time constant on the effect is so long that when you change the pulse width, it just changes how much power they're using. And so the real biological specificity lies in the frequency. What's so cool about this technique, though, is that we can ask them a bunch of questions in the survey, and we can say, Was today's setting better or worse for volitional movement? Was today's setting better or worse for your comfort? Was today's setting better or worse for posture? Was today's setting better or worse for transfer, for rehab, for spasticity? We can ask them questions that quantitatively are just not tangible, but require many years of validating a survey. But we can just ask them straight up. And really all we want to know is it different from movement? For example, if you look at volitional and you look at their preference response and you compare it with spasticity, we see a very different response. And we get all of this data for free, and we get the uncertainties for each one of these. And over time, we can build a very patient-centered model that we can then pool together with some fancy math and draw some conclusions about the population as a whole. But for each patient, we're really trying to find the best settings for them. And we iterate this month by month. And we've done some validation statistics that are starting to tell us that, yeah, this is working. It's difficult. It's a challenging problem, but you're making progress. And it looks like your prediction about what they would choose gets better over time. And what's really cool, one of my favorite plots from the past few months that Zishi made is this plot on the right. And this plot on the right is, on the x-axis is the compliance, the number of responses from patients. And then on the y-axis is how good are we at predicting what their response is going to be for the next settings. And essentially, it's so linear, it's just crazy. It's almost hard to believe that this is even a real plot as we're starting to go through the patients. But essentially, the more responses you put in, the better the model. And that's very simple to say, but to see such a linear response is quite amazing. So, you know, we could say if you want your settings optimized 95%, you got to put in 2,000 responses. That's, you know, 1,500 days. And we've gone on more to help try to understand the very complicated interplay between their neuroplastic effect over time and how much our optimization is working, because we're in a conundrum here where we weren't expecting them to get better over time. And all of a sudden we have to figure out whether our optimization, which is really just trying to give them better and better settings, is causing the changes, or whether or not it's just their plasticity that's causing the change. And this has become a very difficult mathematical problem, but we're making some progress, and we're able to show that if you compare essentially how well they're doing over time, and you look at the effect from just that patient, the individual patient, versus the what appears to just be their natural history versus how much we can explain from our modeling, we're getting more and more significance, showing that, yeah, we're actually making a decent difference by doing this preference scoring over time. And even that problem is difficult because there's a lot of sort of intercorrelation where it's not like 10 months into the study, we're trying to feed them a bunch of bad settings. We have an ethical responsibility to also only try to give them decent settings, so they're going to continue to participate in the trial. So just to summarize briefly, parameter space optimization is challenging, but it does matter. Our blinded forced choice, binary choice, is a really simple thing that could be done really for anything that you're looking at treatment-wise that has a lot of degrees of freedom. And we're able to translate these qualitative preferences into actual robust quantitative modeling that we can then compare amongst patients. The nice thing is we get multi-outcome acquisitions from all of these responses for free, and the surveys are very short. They take 2 minutes at the end of the day. And we're now able to show that we are causing significant improvement from this preference modeling. And that's just the first phase of the multiscalar approach. The last thing, I'm just going to give a teaser because I know this is getting kind of long and I want to open up for questions, is the spatial optimization, which sort of opens up a whole other window of possibilities that we are mostly working on more recently in order to optimize. But with Matt Johnson's lab in DME and his students, we're able to model, we were able to generate finite element models of what's going on here. And they were able to help us put this interface together that allows us to see the stimulation that we're doing sort of in real time whenever we're curious about what effect changing one electrode here or there would be. And one thing that we can do is we can actually evaluate a bunch of different spatial maps and measure the responses in the EMG and take that data and put it back into the model and show where the stimulation is occurring based on where we're stimulating. And then we can actually invert that problem. And we can say things like, if you really want to restore right iliopsoas, based on all the different ways that you could stimulate, what would be the best place? And you can see right in the middle at the top, you would want to stimulate, on the right down towards the bottom, but not all the way down. If you wanted to restore right gastroc, you need to stimulate all the way down at the bottom mostly. And that seems to be the hot area. Now, what we're doing is we're taking that and we actually have to take into account the individual variability of the lumbosacral plexus and that anatomic variability between patients, and then recompute this and say, okay, does this sort of area of stimulation robustly give us right gastroc restoration in the majority of patients? And that's where a lot of that complexity is, taking that into account. So that's just a brief overview of some of the modeling and engineering work that's being done. I do have to thank our what has become a huge team now, Dr. Freeman, one of our residents, senior residents, Dylan, our coordinator, Caleb, our previous coordinator, Aaliyah, coordinator, Dr. Samadani, Aaron Phillips, our collaborator, Shabani, previous coordinator, and Andrei Krasyakov, another collaborator, Patricia at the VA, Dr. Parr here at the university, and then our engineering team, Isabella, who's just become one of our residents, Zishi, amazing postdoc, and Logan, Julia and Nick, and then all the other labs that are involved between Tom's and Tay's and Andy's and Matt's, and Claire, who's moved on to grad school. Our funding and then ways of contacting me. So please, this would be, thank you so much for listening to that long presentation.
Well, thanks for giving that long but pretty impressive presentation. So we appreciate your time. There are a few other questions if you're good tackling them now.
Yes, absolutely.
All right. Let's see here. Functional outcomes for both acute and chronic spinal cord is highly dependent on therapeutic intervention with PT and OT. Chronic patients often need to revisit outpatient therapy almost annually as their function changes as they age with SCI. With decoupling therapy in the study, how can you compare functional outcomes without a structured therapy program post-implant?
Yeah, that's a good question. I think most of the patients, so none of the patients are prescribed therapy, and our idea was they would just continue whatever they were doing before they were enrolled in the study. And most of the patients have done that. Most of the patients still do standing, they still go to therapy once a week, and only a couple have really gone up and above that. And so scientifically, we wanted to decouple that. And so you're absolutely right. We wholeheartedly believe that by integrating a regimented therapy for the patients that took advantage of this personalized optimization and everything would be much better. But at the end of the day, our scientific question was, what is the effect of spinal cord stimulation on movement? And if we had prescribed therapy, we would have to do a sort of either a time-delayed factorial design in order to answer the scientific question we were looking for, or we'd have to do something that probably wouldn't be ethical. So in this specific case, this study was designed not powered to look at therapy as, so I think that's a fantastic point. And we know that this is only the base of how well the patients could do. We think they could do much better once we pair this with an optimized therapy.
Okay. Patients with pure autonomic failure often have high blood pressure at night when supine and low pressure in the day when upright. Do you ever see nighttime hypertension in spinal cord patients?
We like I said, we haven't had any cervical patients, and we've mostly seen we've mostly seen no change in blood pressure for the patients that do have significant cardiac or cardiovascular dysfunction. But like until we actually implant cervical patients, which we are planning to do, I don't think we'll have a good understanding of that.
Sure. Next, when you're fitting these patient-specific Bayes opt models, do you ever go back to a setting that's already been tested to verify that the answer is still the same, even if the model is confident in the prediction at that point?
Oh yes, overlapping settings is a critical portion of how we do the validation. So typically, I would say we repeat their best setting every month. So if in month 1 they had 2 or 3 really good settings, we'd probably incorporate those 2 or 3 good settings into month 2. But also, oftentimes when we're picking new settings, they are closer to setting the settings that were good than the settings that were bad. So, you know, it could be 36 hertz versus 38 hertz. So we're inherently getting closer and closer to an optimal target, and including previous settings. But one of the ways that we validate it is looking at repeated settings, which we often include. I sort of alluded to the fact that I proscribed that we were not allowed to give any significant numbers of bad settings on purpose to patients. So we could have sort of a 10% rate of going out and looking at new novel settings, but we specifically made it so that it couldn't be more than that, so that we're not discouraging patients from participating.
Nice. It looks like somebody, I assume from your lab, was able to chime in and provide also a little bit of information for that question as well. What about static preferences or goals dependent on objective criteria, or a selection of objective criteria going toward an area with the most promise?
I guess I'm not sure exactly what that means. Like specific functional movements, maybe?
Not sure. Dr. Balzer, anything to add to that? Well, maybe we'll let him think about it. It seems that a number of the outcomes would benefit people that were excluded from the trial. What are future plans for this treatment? Would you consider expanding the selection at some point, and any plans for pediatric applications?
Oh, absolutely, yeah. A lot of the reason why we had to exclude populations was not by our design, it was the FDA. And so, you know, this was sort of the largest approved study for doing spinal cord stimulation after chronic SCI. And so we had to push very hard to get where we are with the FDA, but we did plan early on to include younger patients. But spinal cord stimulation is actually only FDA approved for 22 years and older, which makes that challenging. And definitely we'd like to expand this. We don't, you know, the question is, at what point will a company come in and they'll want to make a buck? And so we have to do our best not to be premature about what we're finding, and be generalizable enough that the findings are not so specific that the greater SCI community won't benefit. So a large motivation for us moving forward is to start climbing up for cervical SCI, because that's a huge population of patients that really need it, and we think we can do this safely. And that's the main argument the FDA had against moving towards cervical. They want to avoid ascending edema, they want to avoid hurting patients, which is their job. And so now that we're showing that this can be done safely, I think that that's a realizable next move, which we already have a study in process for doing that and are funded to do so.
Got it. Dr. Balzer was able to provide a little bit. So his question originally was, what about static preferences or goals dependent on objective criteria, or a selection of objective criteria going toward an area with the most promise? He says functional movements, bowel, bladder, blood pressure, finding out which of these has the greatest rise with setting optimization and classifying people into subsets of functional responders, maybe.
Yeah, that's a good question. I think, you know, if you ask, I think a lot of that question boils down to, if you ask one of our rehab doctors, how many SCI patients would you have to see before you said, like, oh, we have a generalizable patient population? And it's like, not 10, and it's not 20, and it's probably more than 50, and maybe even more than that. So that's where a lot of that, not everyone with SCI has significant problems with bowel function.
Sure.
And so I can't make that better. And so that's one of the reasons why we have to sort of do it all at the same time. Now, functional movements, I think, is one of the things that we are particularly interested in. And that's where we think that, our rehab doctors have the most to say and the most expertise and can provide the most guidance. We are very much on the electrophys, neuroengineering, neurosurgery side. But I never wanted to be a rehab doctor. Your job is too hard. And so that's where I think this, there's just such amazing potential for being able to do so and be able to really make a difference. But it's not just going to be neurosurgery.
Right. Dr. Bottiglino asks, what is the maximal functional improvement do you think you can be obtained with spinal stimulation? And is your long-term goal ambulation or hand function, or any long-term goals you can fill us in on?
That's a good question. One of the things that we really haven't talked about today is that, we have only implanted almost all AISAs. And there's a lot more patients out there than
sure.
AISAs. There's a lot of incomplete patients, and others are collaborators that we have, Greg Arquartine, and others have published even better results from patients who are incomplete. That being said, incomplete spinal cord injury is also very variable, is quite variable. And so it's hard to track what the change is. And it's a little bit easier when you're motor complete. But the improvements that they have reported are even more substantial. And so I think that, from my perspective, I want everything to get better. My personal goal is I would like to continue the complicated work of improving volitional movement and movement in general. But I think the patients have spoken, and I can only agree that autonomic function is where we can make significant strides in morbidity and mortality and their preference. So I think that's where we want to continue to head, but we don't want to leave anything behind. We're doing as much, we're trying to address as much as we can, but once this conversation gets bigger and bigger and there are more people involved and we have more patients to actually implant, because still 14 is not a sufficient number to make huge claims from, then I think, everybody is going to have a piece of this ginormous pie. This is just the very start. And if we can make a solid difference, I think that stands in direct comparison with sort of the last 40 or 50 years of acute studies that we've done in SCI with very little studies in chronic.
Yeah. When and how does this move into acute spinal cord injury, from Dr. Morse?
Yes, of course, Dr. Morse. That's that. So my personal opinion about that is, if it ever becomes approved for chronic, it will immediately happen for acute. I think the psychology of acute spinal cord injury is dramatically different from chronic spinal cord injury. It's just, I think the best, my warning is that I think it will work for acute, but if you take someone that yesterday had no problems and today or a week later has a new complete spinal cord injury, and you give them a 2% or 10%, which is my goal in general, a 10% improvement in their spinal cord injury, I don't know how much they're going to notice. Now, it may prove to be extremely beneficial. And I saw Dr. Morse's comments, limiting atrophy, getting them back. I completely agree. I think there's no reason mechanistically why it won't work, but I think it's a harder sell to acute SCI in some ways, and makes it very challenging, when we're trying to figure out strategically as a community whether or not we should start with chronic and go to acute, or how the trials should emerge. There's problems with acute studies, there's problems with chronic studies. I mean, there's problems everywhere. So it's a very complicated discussion, but this is what I worry about, seeing lots and lots and lots of acute. I mean, last week, I got to tell you, with all the trauma that's going on in town, I saw 5 new complete spinal cord injuries. It's just devastating me, not being able to do anything. And there's nothing more than I want to do then instead of doing a 6-hour multi-level fusion to put in a 45 minutes, put in a spinal cord stimulator and see them improve. There's nothing more that I want to do. And there's nothing, and I think they would be happy for me to do it. But I think that's sort of the dialogue that needs to happen. I totally agree. I think it's a worthwhile thing to move towards.
I think it's real astute observation, I guess, thinking about the, I would almost call it patient expectations. You know, when you have such an acute injury, a 10% improvement would be potentially life-changing to somebody who's had a chronic injury and might blend into just the injury overall to an acute patient. So that's very, very interesting. You mentioned that.
So David,
Go.
Brian, if I can just jump in here.
Yeah, go ahead.
Having spent some time trying to recruit patients in the acute setting in the hospital still for a number of trials, I often feel that I'm coming, short-handed, offering statin medication, or in my perception is that people want something more than what I've been able to offer.
Absolutely.
And I think that this would be really, really compelling and well received in acute SCI.
Sure.
Absolutely. Yeah, that's a great point.
Yeah, thank you.
Point.
With the continuous stimulation you allow for enrolled subjects, what's the battery life like in the stimulator? And how can you ensure that with a replacement, aside from surgical complication, you'd get the new stimulator in the exact spot and expect the same response?
Yeah, that's a really good question. One of the problems that we've had is that the current requirements or energy requirements for our participants in this study are much higher than for pain. And so we go through batteries faster, Personally, I think that this is just a really silly engineering challenge, to be honest. I think we can make bigger batteries and we can adjust and optimize. One of the things we're doing now is in our optimization, we're trying to take into account how much battery we're using. And so, for settings that are marginally better, but significantly more resource intensive, we try to get rid of those more quickly. And so I think in, a year or two from now, that will be mostly worked out. And then it really just comes down to the engineering challenge. And I think we can get to the point where we're changing batteries every 3 to 5 years, just like we are for pain. Or, and there's some psychology in this, we can go to rechargeable batteries and we can push on the engineers and say we need better batteries. So I think this is an engineering problem more than a real medical problem. But it's a very good point. In terms of changing the batteries, when you change the battery, it does not affect placement of where those electrodes are, so you don't really have to worry about that. And there's still risk. You could cut the wire, or you could cause an infection. There's still risk, but it's a manageable risk. And there's other technologies that are coming out that could prove to be even better. Maybe battery-less systems that are all done wirelessly, or we didn't talk about it today, but maybe transcutaneous could play some role in this. Although, like I told you, we don't see a lot of neuroplasticity for the autonomic system. So I wonder whether or not you'll still have the same anatomic specificity. But there's other players in the field that will contribute to the neuromodulation treatment as a whole. And I think we'll figure out exactly which ones are working where. But I think a lot of that engineering stuff, it just comes down to, someone thinking that it's a worthwhile issue to tackle by the engineers at these medical device companies. And that is really perception by the community and by providers. And that's really what it boils down to.
Yeah. You touched on it a little bit, that some work's already being done in incomplete injuries by other groups. Any plans for yourself to move into that, and maybe briefly touch on some of their initial findings in incomplete injuries?
Yeah. So I'll say that, Gregoire has a really nice paper showing their results for incomplete. Basically, the short of the long is that you can facilitate much more ability to walk. And so that's very exciting. Like I said, it's hard to interpret these cases because we've all seen incompletes that do even better with rehab. So, natural history versus, but in that case, it's clear that the findings are real. It's just, how many patients do we need to really be able to generalize that? Similarly, Chet Moritz's group with transcutaneous stimulation have really good, seem to have really good effects from transcutaneous stimulation, especially for incompletes. Even improvements in sensation and things like that. I personally gravitate towards the more serious injuries because that's just my personal choice. But I think that the application of this to incompletes may prove to be even better, but more complicated in terms of stimulate programming and figuring all those things out, because we use the brain motor control assessment for the legs. There is one for the arms, but we all know that hand function is much more complicated than leg function in a lot of ways. And so that's one of the hesitations that I've had is, in order for us to go towards cervical, we have to be prepared to be able to tackle the complexities and degrees of freedom of the hands. And that is something, and also there's the role of lower motor neuron injury in the cervical cord, because you have to stimulate right where the injury is. And that makes things even more complicated. So we started with a simpler problem, albeit very complicated. And we've been hesitant to push higher right away because we want to be, relatively confident that we have the expertise that we need. And that's a big part of why I'm talking to you all today.
Mm-hmm. What are your thoughts on any advantages to electrode arrays with larger or smaller contacts?
Yeah, that's a really good question. I think that there is, so I'm conflicted because I have intellectual property on this. So you have to take my word with a grain of salt. And let's be clear about that. I think in general, the more degrees of freedom we have, the more we can do with it, but the more complicated it is. So, I'm torn between wanting to put in 100 electrodes and be able to really shape everything, or say, we already have electrodes, they're cheaper, they'll cost patients less, let's just use those. And I think we can, my rough estimate is that 80% of the effect that you see, we can get the stuff that already exists today. And the last 20% is going to be that extra mile we go with the electrodes, with the steering and all that kind of stuff. That's just my estimate. We don't have hard numbers on that yet, but the next study we're doing is designed to assess if there's a critical density of electrodes that we need to make this better.
Cool. Well, it looks like you caught us up to the end of our questions there. If there's nothing else immediately, then Dr. Darrow's contact information is on the screen here, obviously. I'm sure you would welcome further questions through email or online. We truly, truly appreciate you coming today and giving us 2 hours on your first day out of residency, and congratulations on that.
Thank you so much.
Glad you didn't get any pages during the call today. And,
there's no battery in my pager.
You took it out. Good. It is an exciting time, and this is truly some really exciting work. And I remember when you presented to our program a few years ago on the earlier curve of this project. So it's amazing to see what's come of it. So again, we thank you. Thank you for highlighting the people in your lab, especially a couple of our residents in our program. And we look forward to a lot of exciting things from your work in the neurosurgery department here at the U, and in collaboration with rehab medicine.
Thank you so much for the opportunity.
Great. Thanks everyone for coming, and hope you all have a great day. Take care.